cardiologist from India. It's none other than Dr. Jothydev. So from UK, we move on to the southern tip of India. He's from Kerala. He worked in the government medical college, and he has a lot of interest in technology, and he is one of the first persons to use a lot of technology in diabetes in India. And he has a lot of data, a lot of papers on this thing. So I welcome Dr. Jothydev. Dr. Jothydev, you can share your screen and start your talk.
I think there is a poll coming up. Yeah.
There's a poll question before that.
Yeah.
Do you know anything about integrated diabetes management? I think these things can be answered towards the end during the discussion. This poll is for the audience. Jothydev?
Yeah.
Jothydev, you can take a little more time also because we have a little extra time. You can go up to 30 minutes.
Sure. Let me try. So thank you so much, Dr. Anand sir, for the kind introduction. And let me congratulate once again Dr. Banshi, Dr. Shashank and the team for this first ever biggest virtual diabetes meeting. And I am very thankful, grateful to the team for giving an opportunity along with you stalwarts in technology. And this is my topic. I am going to discuss iPDM, and this stands for Integrated Personalized Management of Diabetes. And this is described as a novel tool for the management of diabetes. So these are my disclosures. And this is a screenshot from one of the telemedicine consultations today morning. And you can see me over there. So this is me over there. So let me have a pointer. And then the hospital staff, and at the bottom there is patient. And I am demonstrating for the patient. So this is a motivational tool from our side. And this is the post-lunch glucoses over the past 13 years. A perfect example of structured self-monitoring of blood glucose. Structured SMPG, and this is just a screenshot. Of course, the patient is doing very well. He is currently 68 years old, a retired person with 18 years history of diabetes, under our care for the past 13 years. And this particular guy hasn't developed any complications of diabetes. He exercises very well. We do a retrospective CGM at least 2 or 3 times in a year. And he comes to the hospital 2 to 3 times in a year. And he is put on a regular telemedicine follow-up with our diabetes team. So this could be an exception. So this could be just an island of prosperity. But if you look at the country as a whole, or anywhere in the world, the prevalence of diabetes, independent of whether it is rural or urban India, the numbers are ever growing. And the average A1C, whether it is from rural India or from urban India, or even in the best of the specialty care centers, the studies have given this evidence. So this is the robust evidence. The A1C is as high as 9 in many parts of the country. And our current aim is to reduce the A1C by at least 1%, reduce the A1C by at least 1% to bring down the microvascular complications by 37%. So why is it not happening? Where is the barrier? So many a time when we are suggesting something to the patients on starting a therapy or changing a behavior, they are reluctant. And this is the question: why our people with diabetes, why our people with type 2 diabetes doesn't achieve their goals of therapy? So I'm pretty sure that many of those friends listening to us, so you were listening to Pratik, you were listening to Iain, and they have described the technologies, they have described the time in range, they have described the necessity of continuous glucose monitoring. But why? All these therapies are available, all these technologies are available even in our own country. Then still, why our patients are not reaching the goals of therapy? Where is the barrier? Probably this is one of those barriers. I would say this is only one. There are plenty of them. Maybe more than a dozen of those barriers are there. But this is something which is very, very important. Clinical inertia or the existence of therapeutic inertia. And this inertia is there for the physician, that is all of us, and this inertia is existing for the patients as well. There is an inertia for adopting technologies. But what I am speaking today is not about technologies. It's about adoption of a systematic and a structured methodology for integrating diabetes care with the existing systems. So the therapeutic failure to achieve the objectives within a reasonable period of time. So we were listening to the enlightening lecture by Iain on time in range. So he spoke about time in range. We need to reach the time in range, and we need to reach the time in range within a reasonable period of time. We cannot keep on watching and waiting and watching and waiting. Then obviously the complications of diabetes will set in. There is a failure or delay in the intensification of the treatment in those subjects who are already on oral therapies and on injectable therapies. And this is again a classical example of clinical or therapeutic inertia, a key contributor to the diabetes challenge. So these are the three important components. I would say that from the healthcare professionals, many of us, we have insufficient time. We have hundreds of patients waiting for our consultation. And some of us have very poor communication skills. We have to admit that truth. Many of us have very poor communication skills. And there is lack of initiating a therapy. We are pretty much aware of the clinical guidelines. We are pretty much aware of the EASD guidelines. We are aware of the American Diabetes Association clinical practice guidelines. We are aware of the RSSDI therapy recommendations. But why there is a hesitancy to adopt those therapy guidelines in practice? PWD stands for the person with diabetes. Many subjects with diabetes, they have very, very limited health literacy. We have to spend some time with them on counseling them, on educating them, on why they have to accept SMBG in practice, why they have to accept at least a retrospective continuous glucose monitoring, why there is significance in reducing hypoglycemia, glucose instability in practice. And they should never be scared of medication side effects. Many of our patients are scared of side effects of medications rather than the consequences of diabetes. So that is so sad. They're unaware or they're not bothered about the consequences of diabetes, but they are very much aware of or bothered about the adverse effects of medications. And the healthcare systems, the payers, the communication difficulties with the authorities, with the regulators. So I would say that the probable remedy will be integrated personalized diabetes management, IPDM, where you consider every person with diabetes as a different individual. And this is of course true. These are all known to us, but difficult to practice. Don't you think that if you have 10 patients with diabetes, all the 10 are different? You have to communicate differently. And the wishes and strengths are different for different individuals. Their weaknesses are different. And their requirements or needs are different. And those individuals with diabetes, so these are the patients with diabetes, they are a player in the therapeutic process. So always remember, they are a component and they are a player. Not only you are just a physician, but you have to involve them in your therapeutic process. They are a member of your team. So in this lecture, in this very brief lecture, what I am going to do is I'll be sharing our personal experiences, as well as I'll be sharing the evidence on integrated personalized diabetes management. First on our personal experience. So we started using the diabetes telemanagement system from 1997 onwards. So it's pretty very old, where there is a team of experts. So it is a multidisciplinary team, and the patients will be reporting their structured SMPG values. So I use the word structured because it is different for different individuals, and the diet and behaviors over the phone or over the email or through the Sequire site. And this has been there existing for more than 20 years now. And the multidisciplinary team will be modifying the medication dosages and behaviors over the internet or over the phone. And this is how we have been individualizing the therapeutic goals. And this is a decision support system. And this is a telecommunication system. This has got telemedicine integrated in it. And it involves empowerment of the patients, continuing education. And since 1997, this is a 24/7 process. And this has been made available both during the night and during the day, ensuring compliance. And this is one example of how we have been administering the customized educational modules via the internet, via the telemedicine. And I will just showcase a couple of publications based on DTMS. And this is in diabetes technology and therapeutics, the cost-effective use of telemedicine, along with structured self-monitoring of blood glucose. And this is our system, diabetes telemanagement system. In 1,000 patients, all of them eligible for an A1C reduction of below 6.5 without the occurrence of serious symptomatic hypoglycemia. So if you look at the A1C values at baseline at 3 months and 6 months, so this has been achieved without the occurrence of any serious symptomatic hypo episodes. And a couple of years later, in 2015, we have come out with a review on the sustainability of this program. So in this review, the free text is available in the internet. We have very openly discussed the challenges that we have faced running this program for the last more than 15, 17 years. That was in 2015, and the merits and demerits. So what are the challenges we have described? And many app developers have probably emulated, and they have been very grateful for us for openly discussing not only the merits but also the challenges. And this is one study on the cost effectiveness of A1C lowering with the help of structured SMPG program. And another one on geographical location. So this can be totally independent of the geography of the person. The patient can be from a neighborhood or they can be from another continent. But the effectiveness of DTMS along with SSMPG remains the same, where it has proven superiority in ensuring multi-drug compliance. So apart from managing hypo, overcoming hypoglycemia, and the so-called therapeutic inertia, this is another major barrier in diabetes, ensuring drug compliance, which can also be carried out, which can also be ensured with the use of SSMPG and telecommunication via virtual consultations. So getting back to the structure of iPDM. So this is a Roche developed program, the integrated personalized diabetes management, and it has got 6 major components. So the first component will be a structured assessment and training. So we are assessing the patients on where exactly he is positioned today. So what is his type of diabetes? Has he developed any complications of diabetes? What are the comorbidities? What is the glycated hemoglobin level? Are there any previous history of very serious hypoglycemias? And the next step will be a therapy adapted SMPG. So the SMPG has to be customized, predefined, and structured collecting of SMPG data and structured documentation. So you have the therapy management software and the data can be downloaded. So this is another example of the big data analysis where it is automated and then systematically analyzed, ensuring adherence to the SMBG, that is monitoring, and then detailed discussion on the SMBG reports and the recognition of patterns. You know that many of the modern day glucose meters are capable of generating data, the graphs and the trends very similar to the CGM, where the patients cannot have CGM all the time. And it can also even provide the data, color-coded data on the time in range, time above range, and even time below range. And the personalized treatment, that is the fifth component. The joint evaluation of the success of modifications in the therapy and implementation of the agreement. So everything is based on personalizing the treatment and a shared decision making, where you as a doctor, me as a doctor is only one component, and the patient along with you and the team will make all the decisions. And periodically you have to reassess the treatment. You have to reassess the effectiveness of the treatment, and this cycle goes on like this. So this is a summary, the result. So you start with assessing the patient, and this is along with structured education. So some patients will require more education monitoring. Some other patients will require more education on their injection techniques. Some other patients will require more education on how they can connect their mobile phone with the glucose meter. So most of these glucose meters are now Bluetooth enabled for connectivity to the mobile phone. And this will result in a structured SMBG monitoring and then automated data visualization of the graphs on the pattern recognitions. And then you're going to analyze, look at the picture. You're not alone. You are there along with the patient. So it is a team effort. And then personalizing the treatment supports improved therapy results, contribute to motivation and therapy adherence. And ultimately, along with therapy efficacy assessment, this results in simplification and eventually implementation into the daily routines of the subject. So let me now very, very briefly go through the Pro-Value Study Program. And this is the study which has resulted in the evidence on the significance of the integrated personalized diabetes management. A randomized prospective controlled intervention study in 907 patients in Europe from 101 sites, all of them having type 2 diabetes. They were on different insulin regimens starting from multiple daily injections, premix insulins, basal therapy, and so on. So they were not only matched for the sex, age, BMI, duration of diabetes, or baseline A1C. They were also, both the cohorts, the test and the control were also matched for the frequency of SMPG. So that is quite interesting. So if you look at the iPDM cohort and the control cohort, both the groups were having almost similar frequencies for the self-monitoring of blood glucoses. So obviously, both the arms could have resulted in significant improvements in the blood glucoses. And the difference will be the iPDM in the other group and SMPG in both the groups. And there is no iPDM in the control group. So I will summarize the results like this. So these are the primary endpoints. The primary endpoint is, of course, the A1C reduction at 12 months. And the secondary endpoint will be the patient-related outcomes. And there is a comprehensive evaluation, both outcome and the process and measures of effectiveness. So these are all the 6 steps of iPDM which is administered. And the AccuCheck meters were used in the intervention group, since it is a Roche-supported program, the iPDM and the Pro-Value Study. And look at the way it has resulted in the changes during the study process. There is early recommendation of therapy adjustments in the iPDM group. It resulted in earlier and more focused adaptation of nutrition counseling, significantly more, lifestyle changes, significantly more, and more adoption of intensification of therapies and insulin use, 35 point, almost 36% versus 27.6% in the control group. With process improvement, patient adherence, more in the iPDM group, better control of glucoses, and collaborative patient-physician communication resulting in satisfaction for both the physician and the patients. So there is rapid, within the first 3 months itself, there is a rapid drop in the hemoglobin A1C in the intervention group. So you can see the rapid growth in the A1C value of 0.5%. And this 0.5% reduction, more patients achieve an A1C reduction with the iPDM when compared to the control group. And iPDM works especially more effectively. So higher the A1C level, more effective will be your integration of diabetes with SMPG. And the hemoglobin A1C reduction in both the groups. So I would say that both the groups, both the control and the iPDM group, since both of them were having almost similar frequencies for SMPG, and the drop in A1C has resulted with no increase in hypoglycemia. So always I tell my patients that whenever you are more frequently measuring your glucoses, let it be with your glucose meter or with your CGM, there'll be less chances for hypoglycemia and more chances for you to reach and sustain your glucose goals. And the physician recommended lifestyle interventions were also significantly more in the iPDM group. So that includes diabetes training recommendations, physical activity recommendations, nutrition counseling recommendations, and podiatry recommendations. All of them significantly high in the iPDM group compared to, in contrast to the control group. And the iPDM group invariably reported better adherence to the instructions. This you have seen in our studies as well. When you are having constant communication with the patients, it results in better adherence to all your instructions. And why the patients are uncontrolled? I am back to the billion-dollar question. Despite the availability of all these technologies, despite the availability of more than a dozen new medications for diabetes, despite the availability of all these injectable medications, including incretins, why do still our patients are having uncontrolled glycemia? Now, let me discuss some solutions, some viable solutions which I could generate from the integrated personalized diabetes management, iPDM. You have seen significant improvements in A1C. You have seen better satisfaction both for the patient and for the physician, less occurrence of hypoglycemia, and more adherence to the treatment protocol. So now let me move on to the solutions. So this is a picture. This is a picture taken in one of the ATTD meetings in Vienna. So this is Frederick Debong. So Frederick Debong, you can see this is this guy very near to me on the left of my mind. This is at Vienna. You can see George is along with me, and this is the Roche booth at ATTD at Vienna. Frederick Debong is the co-founder of MySugar. So this is MySugar. What is MySugar? MySugar is the most popular diabetes app. And currently there are 2 million users all over the world. The commonest, the most commonly used and the most popular diabetes app. And this is the guy who is one of those founders, Frederick Debong, and he himself is having type 1 diabetes, and he has lived with diabetes for over 30 years. And this has been recently acquired by Roche. And this is capable of automatically drawing the glucose data from meters. And these are the connected glucose meters. And it can automatically provide you, if you have enough data fed on it, the insulin carb ratio, the insulin sensitivity factor, and so on. Almost all the insulins are listed in it. So there are unlimited possibilities with this MySugar. And this is how a connected glucose meters can provide solutions for you, the iPDM. So we have the AccuCheck Instant and the Guide meters over there, which are connected meters which can work along with MySugar. And currently, some of these insulin pens can also be connected with MySugar via near-field communication, where you have the Bluetooth-enabled insulin pens and the data can be transmitted and an algorithm can be created along with the CGM. So the CGM from Dexcom, from Abbott, they can also be connected by insulin pen. So all these devices can now be wirelessly connected. And this is an example of connected glucose meters and how this can result in an integrated solution for better outcomes in diabetes. So your cost is going to be less, the time you are going to spend with your patients are going to be less, but your outcomes are going to be much, much better. And this is another interface of MySugar, which is showing the hypo data, the hyper data. It's all color coded. It can generate the data on time within range. The digital diabetes diary can be emailed to the doctor's office in the form of a PDF, or you can generate a CSV file for your research. So unlimited possibilities. So one more innovation which is coming up, and that is AccuCheck Sugar View. This is my last slide, one of my last slides. So Sugar View is a meter-free blood glucose testing mechanism. So we have been using glucose meters for the last several decades. So we are soon reaching an era where probably we'll be using more of CGM devices, but the glucose meter might get replaced with your smart mobile phone. So this is one such CE approved device, and this is not a device, this is just a mobile phone application where you will take the picture from the glucose strip. So this is AccuCheck active glucose strip, glucose meter strip, and you take two pictures and then you compare with the colors. It will not give the exact glucose value currently, but it will give you a range of the glucoses. For example, 70 to 130 in green will be within range, and 20 to 70 will be low, and 301 to 600 will be very high. So this is probably ideal for those with pre-diabetes or with type 2 diabetes requiring only lifestyle modifications. So the technologies are fast developing, doing now what patients need next. So I would like to have the summary slide over there. iPDM represents an easy to implement approach with an integrated software solution. It is a low cost solution. So there is no extra cost involved in the use of these apps and in the use of these connected glucose meters. It is a continuously growing population, type 2 diabetes, and these novel diagnostic tools are even compatible. These novel integrated solutions are compatible even with the CGM devices. And we are proud and privileged to partner with Roche, and our center is a Roche recognized integrated personalized diabetes management center of excellence in India. So thank you very much for the opportunity and for the patient hearing.
Thank you. Thank you, Dr. Jothydev. Visual from you. We'll now move ahead with the question and answer section and the panel discussion that we have with all the speakers. Okay. So all the speakers are here, I suppose. Do we take on the poll questions first, or we'll first go through some of the questions that we have? So one of the questions to Dr. Cranston is that, Dr. Cranston, regarding the time in range, do you think will it complement or will it replace HbA1c in the near future?
So I think if the uptake of things like CGM becomes fairly universal, then I think there's no reason for somebody using CGM to also measure an A1C, actually, because all we measure with the A1C is an indirect way of measuring the mean glucose. If you have somebody who's already continuously measuring their mean glucose all the time directly, to repeat those seems to be unnecessary. However, I think being more of a realist, it's likely that not everybody will be using CGM for the foreseeable future as a 100% process. So I think that the A1C is certainly still going to be used. We know that time in range, if you do structured glucose monitoring and you do the structured glucose monitoring more than 4 or 5 times a day, we know that the time in range data that you will get from that is at a population level broadly comparable with the time in range data that you see from CGM. Although, as we already heard from Dr. Kesavadev there, the structured monitoring will potentially differ from person to person. And so the actual, if you have an individual who you are very concerned about hypoglycemia risk, then their structured monitoring may be very much targeted towards minimizing their hypoglycemia risk. So their time in range may not reflect the entirety of their 24-hour period because of that. So I think that the time in range is best for true CGM devices, but it certainly can be used as a useful metric alongside structured SMPG data, as long as we take a little bit of a pinch of salt to the absolute results with it.
There's one of the questions in the chat section says, how do we manage the clinical inertia? I think that Dr. Jyoti can answer that.
Yeah, Dr. Tejas, thank you. Well, clinical inertia is something very difficult to manage. Obviously, clinical inertia is existing more for doctors. Of course, it is there for patients. So whenever we suggest an injectable therapy or a new therapy which is currently having evidence to a patient, the usual response will be, doctor, my blood sugars, I know it is slightly on the higher side, but please give me 1 more month, or please give me 3 more months, I will control and come back, right? So that is the usual response. So here, I think the best solution will be spending extra 5 or 10 minutes with the patients and explaining them on the consequences of diabetes, on the complications of diabetes. And it's always better to highlight the cost which is involved and the disability which is involved with the consequences of diabetes. So after 10 years, what happens? After 15 years, what happens? And what can you do at this moment of time? So this is how we can educate and counsel the patients in groups or in one-to-one conversations. And this is what the ADA calls as a structured program, an integrated program, and a shared approach. So it is a team effort and customizing the requirements of the patients. But I will say that more important will be the programs like this. So this is an event where we are communicating and interacting with the physicians. So from the physicians, there is a vast majority where there is an inertia to adopt the newer diagnostics and therapies. And that is also coming under the definition of therapeutic inertia. So we have to keep on telling them, keep on educating the physicians, because diabetes is majorly managed by the general physicians and the general practitioners, where they will have less of an opportunity to be part of programs similar to this. So we have to penetrate into those areas. So this is one of those opportunities. Since many of them cannot attend our in-person or conferences, these virtual platforms are opportunities for all of them to attend, and one of the solutions on how to overcome the inertia.
Thank you. Thank you so much.
There's a question for Dr. Cranston. So how do you select your patients for CGMS? Do you want all your patients to have CGMS, or you select your patients?
So both myself and Pratik, who I think can't be in the discussion because he's actually in the other hall at the moment doing the talk, we both work in the NHS, and so the NHS has eligibility criteria for the use of CGM at the moment. The eligibility criteria for the use of flash CGM, or the Libre, has been made significantly broader than the eligibility criteria for real-time CGM, which reflects, I think, at least in part, the relationship between cost and effectiveness that we see with the two, because it remains the case that most of the real-time CGMs remain 2 to 3 times as expensive as the flash CGM does. So flash is the more widely available, and is available largely to people with either type 1 diabetes or insulin treated in terms of multiple daily dose insulin, usually type 2 diabetes, but who have other specific comorbidities. So it's all type 1 with potentially multiple daily dose managed or CSI managed insulin, or type 2 in specific population groups. And obviously the specific population group closest to my own mind, if you remember my bio, is the group of people requiring renal replacement therapy, who have a wide variety of challenges alongside glucose management as well. So at the moment, as Pratik mentioned in his thing, that means that we probably have access overall from in people with type 1 diabetes of around about the 30% mark. The principles of eligibility, I think, are being challenged at the moment, because the original principles were based upon, unless somebody has already got some experience of looking at their glucose levels, how will they use CGM data effectively? And I think some of the data that's come out from some of our colleagues in Scotland, where they've taken a much more broad brushstroke to using the Libre particularly, has been that actually people with no previous experience can actually use the data very effectively and often do very well from that point of view. So we're at the moment in a process that's probably expanding that, because certainly last week's American Diabetes Association meeting started to have large population data sets showing the fairly dramatic savings that can be made by offering CGM more widely, in terms of very dramatic reductions in DKA admissions to hospital, severe hypoglycemia admissions to hospital, and actually admissions overall to hospital. So the emergency glucose-related admissions to hospital, and there were 4 or 5 similar presentations, are being halved by the use of more open access CGM in terms of Libre. The real-time devices in the UK at the moment, where we are a little bit cautious about overspending money, are more limited to individuals who have very specific hypoglycemia-related problems, where an alarm, or particularly a predictive alarm, is felt to be important as part of their management. Does that help with that answer?
Yes, Dr. Jothydev, you're there?
Yeah, yes, sir. Yes, sir.
Can you add something on the Indian situation there? How do you select your patients? So here, most of our patients have to pay from their pockets for their CGMs, unlike the UK, where the NHS probably helps them in the CGMs. And so, do you think a selection of your patient is slightly different from what Dr. Iain said just now?
Of course, we do have the CGM guidelines in India too. And there is a selection criteria. So for us, what we have decided is we have to advise a CGM if the glycated hemoglobin is persistently raised, remaining high,
how high?
Despite your multiple daily injections and all other therapies. Am I audible?
Yes. How high? I said. Is there a cutoff for HbA1c?
If it is persistently more than 9, but the cutoff value will be when you are customizing the glycated hemoglobin for patients, and if it is remaining higher for that patients, because we have currently 3 categories where we will have 3 categories of patients and 3 A1C targets. So if you go by that criteria, and second will be when there is a disparity between the measured glucose values in the glucose meter and the lab measured glycated hemoglobin. And the third criteria will be the patients who are having recurrent episodes of either hyperglycemia or getting admitted for diabetic ketoacidosis very frequently. So in type 1 diabetes, absolutely, no doubt, we have to have, if possible, a real-time CGM. But in India, currently, the most popular CGM, I see a question over there on the popularity of CGM, right?
Yes.
Which one is used more? Right, Anand Master, sir, can I answer along with this?
Yes, you can club them.
Yeah, club, yeah. And obviously, because I still remember it was in 2006, the CGMS Gold was launched in India, and it was used more often as a research tool. But in 2015, the Abbott Libre Pro was launched. And ever since Libre Pro was launched, Libre Pro used to be a very popular CGM in India, replacing, of course, iPro 2 is still existing, but Guardian Connect, especially the 3rd generation, GS3, has become very popular as a real time, because the a mean absolute relative difference of the Guardian sensor when it is put over the upper arm. It is around 9.3 if I am not wrong, because Cranston can correct me if I am wrong. So if it is on the upper arm, the Guardian sensor 3, it is much more accurate. So, but it is slightly more expensive. So Libre Pro is very popular. So I would say that in our practice, ever since the ADA recommendations on time in range, and that is somewhat like an endorsement for the use of AGP report, which can be generated from any CGM. Ever since the recommendations from the International Diabetes Center and then adopted by the AS and then by ADA in 2019 and appearing in the guidelines in 2020 on the AGP report, the use of ambulatory glucose profile from any CGM, especially from Libre Pro, it has tremendously gone up because it is a very, very cost-effective, very cheap tool for measuring the AGP. And currently, there are many patients. I would say that there are, though it is not accurate, there are many patients using the Libre Pro along with the GLIMP app in the phone. So it is not a recommended one. It is a third-party application in the phone. But patients, even with type 1 diabetes, because you expect more glucose variability and sudden fluctuations in type 1 diabetes. But even for those patients, they say the differences are quite less. And they are using it as a real-time device in both type 1 and in fully blown out type 2 diabetes. So the use has been very high nowadays. But in our practice, we are using Libre Pro and Guardian Connect, especially Libre Pro as a retrospective device. Earlier, it used to be iPro, even in patients with subjects with pre-diabetes. Because we have seen the continuous glucose monitoring data, retrospective data as a highly motivational tool for pre-diabetes patients. Whenever they see that this is the time the glucoses are going up, so this is the food that has resulted in this spike, then there are higher chances, which we have already established. We have also presented in some of the international conferences. And this has been shown that this has been very successful as a motivational tool, since it appears as pictures and graphs for the prevention, progression of pre-diabetes to diabetes, for those subjects to adopt healthy lifestyles to prevent the onset of diabetes. So CGM for us, I will say that it has got a broader perspective. So this can be in type 2 diabetes, in type 1 diabetes, in pre-diabetes, and if possible and affordable or eligible in all our patients in practice at least once in a year.
Thank you. Thank you, Dr. Jyoti. One question maybe both of you can answer. First of all, with the frequency of CGM specifically in UK, Dr. Cranston, how often do you ask for this to patients? And Dr. Jyoti, looking at the Indian scenario where it's a self-pay market, what do you think should be the ideal frequency that you should be asking?
So when you talk about frequency, I guess you're talking about this idea of the professional or blinded CGM. The majority of CGM use in the UK is not that use. The majority is personal use, so being used continuously all the time. The population groups who I do will do retrospective professional type monitoring on, and I do that fairly regularly in the dialysis population that I look after. I will tend to do that in people who have a fairly settled profile. I will do that once or twice a year. And for people who have a anxiety producing profile, we will usually make a change and then look again a month later to see whether we've impacted that. Because I think the beautiful thing about retrospective CGM is that you can see whether clinical changes have made a difference to the person's glucose experience. And once they achieve, and the nice thing about the 14-day profiles is we know if you get a 14-day profile that's fairly stable, we know that projects forward into a predictive value for the future. That for most people, we know that a good 14-day profile, unless other things change, will predict at least 3 months into the future. So the logic would be you wouldn't need to be doing it more than 3 or 4 times a year when things are steady. But in fact, in the UK, we do it a bit less than that. We do it once or twice a year.
Dr. Jothydev?
Yeah, almost the same. I totally agree because they are the leaders. So I agree with what Cranston says. But for us in India, as you say that we are more or less a poor country and patients have to have this from out of the pocket. And here we are again customizing. But I would say that the accuracy of these devices is of something which is of prime importance. So we have to keep on telling our patients and our colleagues that this is not the glucose numbers we are assessing. It is more to do with the trends and with the graphs and with the time in range. And most of the time in research, we eliminate the first 2 days and the last 2 days when we are uh, assessing the LibrePro results, since the 10 days is sufficient for generating the AGP as well as generating the data for performing the research. But anyway, I would say that when compared to what it used to be in 2015 and 2016, the accuracy has tremendously increased, and most of the time it used to be very low in the hyperglycemic range. So many such obstacles have been overcome now. So even for the glucose meters, I would say that many patients and even physicians are not aware about the difference in the accuracies of these meters. So many branded glucose meters are slightly more expensive, and patients and many of our colleagues will go for inexpensive meters, and what they compromise on it is accuracy. So accuracy of these devices are of prime importance. And LibrePro, the Guardian from Medtronic, they are all fairly accurate. And with regards to the frequency, I would say that I will go for a structured SMBG more frequently. So structured SMBG can be weekly, can be once in 2 days, and it is less expensive. And for those patients who require a CGM, I will again customize. But on an average, I would say that in type 1 diabetes, it could be much more frequent. It could be 1 or 2 times every month, or 3 or 24/7 if possible, especially real time. And even unaffordable and the societies are getting support from various organizations and from the government in Kerala for continuous use of CGM devices. But for retrospective CGM with the LibrePro, the minimum recommendation I would say will be 2 times a year, and if possible 3 times a year.
Jothydev,
Thank
you. As you said, most of our patients are managed by general practitioners. Probably it's the same in Kerala, and who may not have access or time for advising patients on CGMs or sitting and analyzing the results, or the backup team that you have all may not have. So do you think there is still a role for SMBG, 6.8 point SMBG, which can roughly give the time in range also? Is there any comparable study with SMBG time in range and your CGMS? So that
yes, even the Bergenstahl report on time in range, it has been generated from the SMBG data originally, because all these original ideas have been generated from the DCCT trial. So glucose meters used to have a role, and they have a role, and they will still have a role. That absolutely no doubt. And you cannot replace glucose meters that easily, but there will be a time probably in the near future where the glucose meters will be replaced by the more accurate and less expensive, because I am aware that less expensive CGM devices are going to get launched very soon. So it will gradually replace the glucose meters, but more than 90% of our physicians and patients will be using only SMBG and glucose meters, because the glucose meters are time tested. But the take home point will be whatever you are using, it should be accurate and should be properly educated. And even SMBG penetrance is less in country. So with CGM penetrance, luckily the SMBG is also becoming more popular now.
yes. I think it's organizers. Do we have time for 1 or 2 questions, or it's over?
One last question you can have.
Yes. This CGMS, Professor Dr. Cranston, is it to empower the patient more or the doctor more, do you think, in the treatment?
So I think interestingly, the evidence for CGM use, and at least published evidence, is far stronger for patient use than for healthcare professional use.
Yeah.
So the individual with diabetes affecting their own experience of glucose on the basis of feedback from their data has been a far more well evidenced outcome. What doesn't persist and has been the disappointment about the intermittent use from that perspective is good habits that may be learnt whilst using CGM tend to fade very quickly when CGM is taken away again. So whilst we know that benefits that accrue, for instance, during 3 months of wear, by 3 months of non-wear have basically disappeared again. So the rationale for CGM use on a personal level is that if it's helping, they'll need it all the time. The challenge, I think, for professional CGM, because I think professional CGM, this idea of doing intermittent therapy changes and behavior changes associated with an assessed profile, is one that the barrier, I don't believe, is the technology. I believe it's actually us, the healthcare professionals, having the confidence to actually interpret and give good management advice based upon the information we see. I spent 6 months of my life analyzing 6-month data profiles from 2 of the intervention studies that were done with CGM. And what's very clear when you look at the clinical consultations and the management changes were not those being made based on the data they could see from the sensors. The data they could see from the sensors would have given very different management decisions than what they actually applied in the studies. So I think there's a learning curve for us as healthcare professionals to get better and better at this process.
Yeah. Thank you.
Thank you. Thank you, Dr. Cranston. And you had a wonderful session, an opening session. Nothing could be better than this in today's time, especially when we are talking about technology and diabetes, and especially in times of COVID. We have had an update on new technologies. We have had the importance of CGMS, and we have had the importance of telemedicine in today's times. So with that, we conclude the first session today. And thank you to all the speakers for the wonderful effort and wonderful time that you all have given. And I hand it over to the host now. Thank you very much.
Thank you. Thank you. Thank all the speakers and the panelists. Thank you. Thank you, Dr. Shah.
Thank you all the speakers, Dr. Iain, Dr. Pratik and Dr. Jothydev. And thank you so much to our chairpersons, Dr. Anand and Dr. Tejas sir, for the concluding of this wonderful session on technology and monitoring in diabetes. We had a wonderful time, and now we are proceeding to the next session, that is a lipid session. Lipid symposium. We are fortunate here and we are privileged here to welcome our chairperson. First of all, I would like